seen in goiter. In 40% of cases, mutations leading to the activation of the oncogene RAS results in downstream upregulation of genes responsible for cell growth. So we've brought back our recurring RAS rat, the quintessential evil crime boss pet. Oh, who's my little tumor-ridden bundle of joy? Yes, you are. Yes, you Dick. Patients with follicular thyroid carcinoma most often present with a solitary, painless nodule. It tends to not spread to lymph nodes, but may spread hematogenously to the lungs, bone, or liver. Histologically, follicular carcinomas range from well-differentiated tumors with a nearly intact capsule to invasive carcinomas with extensive vascular and capsular invasion, as depicted by that broken glass capsule. Speak to me, squeakers! Speak to me! Microscopically, they're actually identical to follicular adenoma cells. Remember that jetpack guy from earlier? She's even dragging the same follicular net behind her, with sheets of normal-appearing thyroid follicular cells surrounding colloid arranged in uniform follicles, similar to what you'd see in a normal thyroid specimen. In fact, the only way to differentiate between follicular adenoma and follicular carcinoma is to demonstrate capsular invasion by the tumor, which involves surgical excision of part or all of the thyroid and careful histologic examination. All right, time for some good old-fashioned hand-to-hand combat with the big boss herself. Dr. Anaplastic, wearing, as always, her signature plastic suit. Anaplastic thyroid carcinoma occurs most often in the elderly population, at an average age of 65 years. It's by far the worst of the thyroid carcinomas, with nearly 100% mortality. Though, I've only heard of how sinister she is. She could be a nice old granny. See? She's waving. Just a friendly nope. She's giving the old kill signal. Yeah, she's evil. Anaplastic thyroid carcinoma can arise de novo or from a prior papillary or follicular carcinoma. So we've parked our follicular helicopter and papillary propeller boat nearby. Anaplastic thyroid carcinoma is most often associated with loss of function mutations in the cell cycle regulator gene P53. It's the classic cell division checkpoint gene. So at Sketchy, we show a loss of P53 as a broken checkpoint gate. This cancer type can also feature RAS or PIK3 mutations. As I said, this cancer is quite aggressive. It often invades local neck structures and can even lead to compression of the trachea, which I'm sure that guy is feeling right about now. Under the microscope, anaplastic carcinoma often invades and extends past the thyroid capsule. They have poorly differentiated cells, hence the name anaplastic, which range from large and pleomorphic to spindle-shaped, depicted by all those weird cell shapes formed by the cracks in the skull base. You'll also find many mitotic figures and areas of necrosis. The skull stands for necrosis, while mitotic figures are depicted by the skull's eyes. Mitotic figures are cells in the middle of dividing, with a dark tangle of condensed chromatin that's just about to split in half. About to do that whole anaphase thing. Treatment is palliative at best, such as surgical debulking for tracheal compression. Sadly, anaplastic thyroid carcinoma is almost 100% lethal. All right, we're going to wrap up this scene with medullary thyroid carcinoma. This one happens between the follicles. See how we've placed that cancer crab on the land in between follicular puddles? Think of this as the central tissue or medulla of the thyroid. Medullary thyroid cancer is pretty unique because instead of coming from the follicular epithelium, these tumors arise from parafollicular She cells. Seashells. Pineapple. The pineapple is the pinnacle of produce. Let's try that again. These tumors arise from parafollicular C cells. Those guys that secrete calcitonin. Remember? No? Well, as a reminder, the parafollicular C cells are neuroendocrine cells that hang around in the periphery of the thyroid follicles and help regulate body calcium by releasing calcitonin. That's why all that neuroendocrine wiring is visible along the side of the tower. Medullary thyroid carcinomas only make up about 1 to 2% of primary thyroid cancers. Up to 80% of cases are sporadic and typically occur in the 5th to 6th decade of life. Meanwhile, the remaining 20% of cases are familial and part of the autosomal dominant multiple endocrine neoplasia syndrome types 2A and 2B. So we've brought in some backup. Agent 2A and 2B from our Men in Slack sketch. Men 2A is associated with medullary thyroid cancer, pheochromocytoma, and primary hyperparathyroidism. While MEN2B is associated with medullary thyroid cancer, pheochromocytoma, marfanoid features, and mucocutaneous neuromas. Check out our upcoming multiple endocrine neoplasia sketch for more info. In cases of familial medullary thyroid carcinoma, the age of onset is typically younger and can even occur in children. In the majority of both familial and sporadic cases of medullary thyroid carcinoma, the underlying pathogenesis involves activating mutations of the RET proto-oncogene, a tyrosine kinase. As with most thyroid carcinomas, patients typically present with a painless neck mass, and it can spread to the cervical lymph nodes. Like I said, medullary thyroid carcinoma develops from C cells, so it's probably not surprising that medullary carcinomas produce calcitonin. Just think of this tone getting transmitted by the C satellite. Calcitonin serves as a tumor marker and aids in diagnosis, although calcitonin's major role is to lower serum calcium levels. High levels can lead to diarrhea, which can be a symptom of medullary thyroid carcinoma. The mechanism is not clearly elucidated, but may be related to increased gut motility and/or disruption in small intestinal fluid absorption. Also, since medullary carcinomas are derived from neuroendocrine cells which secrete hormones, expect some extra hormonal signs and symptoms. For example, vasoactive intestinal peptide that gets released leads to diarrhea, serotonin causes flushing, and ACTH leads to Cushing syndrome. Notice the VIP door underneath the serotonin smiley face window and Cushing moon facies window. Histologically, sporadic and familial medullary carcinomas are pretty similar, with just a few exceptions. First, both present as solid masses with areas of necrosis and hemorrhage, especially in large tumors. Hence the large necrotic skull at the top of the base. Under the microscope, medullary cancer cells are polygonal or spindle-shaped and form nests, kind of like that nest of spindle shells. Being neuroendocrine cells, they also have dense secretory granules in the cytoplasm. A unique feature of medullary thyroid cancer is that calcitonin precipitates in the stroma and forms amyloid deposits. It'll look like puddles of pink gunky material on your slide. Yep, that's our recurring amyloid armored lady, activating the distress signal. Remember that amyloid is visible with Congo red staining, turning it red under normal light microscopy and green under polarized light. In our upcoming Men in Slack sketch, we'll show a few more features common to familial medullary thyroid cancer, including the presence of multiple bilateral tumors and C-cell hyperplasia. C-cell hyperplasia involves a diffusely increased mass of C cells, which have clear cytoplasm and prominent nuclei, lining the basement membrane of follicles, not invading it. Patients diagnosed with medullary thyroid carcinoma should also undergo genetic testing for germline RET mutations, as well as imaging to investigate the presence of other tumors, such as pheochromocytomas. Treatment for medullary cancer is total thyroidectomy, and serum calcitonin can be used to monitor patients for recurrence after treatment. All right, that's it for thyroid nodules. Remember, there are non-neoplastic causes like multinodular goiter, cysts, and thyroiditis, and neoplastic causes, including benign follicular adenoma and malignant carcinomas. The four major types of thyroid carcinoma include those of follicular epithelial cell origin, such as papillary, follicular, and anaplastic thyroid carcinoma, while medullary thyroid carcinoma arises from the parafollicular C cells and can be associated with MEN2A and 2B, as well as all kinds of neuroendocrine hormones. Anaplastic is the bad one. You've got anaplastic cells on histology, necrosis, spread to surrounding structures, not good. Remember, Dr. Anaplastic is not waving a cordial hello. Learn that the hard way. Follicular carcinoma is characterized by lots of follicles on histology and invasion past the capsule. Papillary carcinoma is characterized by those dense cellular finger-like projections, somoma bodies, and orphan